ictal depression, because the action potentials have been floating around, bouncing around in the brain like a demented chipmunk. And what you'll see, well, think of it. What you see is every neuron in the brain is firing. A lot of glutamate's released, so they could have brain damage. But why does the seizure finally stop? Because finally you release enough GABA that the seizure stops. So they have the period of post-ictal depression. But it is important to realize that most of your anti-epileptics have to work in concert with GABA, right? Let me see, try to remember the password. I use a different password for every account I have, so sometimes it's a pain in the neck trying to remember it. So, if you see seizures, you'll see that there are partial epilepsies, partial seizures, where maybe like the hand goes, or you like have a facial grimace, or you might have myoclonic jerks. Well, those are partial seizures. Those are partial epilepsies. And they're dramatic and they're important. But then you have the major motor seizures. And these are the ones that are most dramatic. Okay, when it comes to seizures, they are triggered in the brain, obviously. They're triggered in the brain, and there's always a trigger site, the loci, or focus. You don't have to write this down, it's all on the slides, don't go too crazy. You always have a site that is insulting. I don't want to say insulting. Something goes wrong.
And, as I've said, a collective designation.
Apparently this is a one I narrated.
You'll see that in the case of
And
epilepsy, there's always
can't
some
figure out how to
pacemaker
get the voice out.
or some site that
Let's see.
serves as a initiator of seizure.
Yeah, how can we just play that?
A site that is a focus. This focus acts as a pacemaker, generating a series of low frequency, high amplitude waves, which are ideal for synchronizing the brain, and then spreading epileptic activity to other areas of the brain outside of the focus.
Oh, I know what will work. There. Can you see it when I do it that way? All right, so do that. Okay, so there's always a metabolic derangement, an ionic or electrolyte derangement, a structural derangement, something physical, anatomical, and an area of the brain becomes a pacemaker. You'll see that quite often the seizure threshold, or after discharge, the threshold lowers. Now, oh yeah, I already did, I think. Did I do antipsychotics with you guys? I think last semester? Yeah. Well, no chance in hell. I would have mentioned that the antipsychotics reduce the seizure threshold, and some antidepressants, and so even drugs can do that. But what you'll see is that there is some area of the brain that will begin to act like a pacemaker. That's called the locus or the foci. Let's see. Yeah, it's what we got there. And that begins to generate high amplitude, low frequency waves. Now you don't need to know that either, but what's important, this is ideal for spreading electrical information through the brain and synchronizing the electroencephalogram. And in fact, any drug or chemical, or in this case disease, that causes synchrony in the electroencephalogram makes it easy to precipitate seizures. Seizures themselves are synchronized waves. In fact, if you specialize in neurology, you can actually classify different seizures by the types of electroencephalogram that's formed. All right, so you have a loci, you have a focus. Let's see. Okay. Wait a second. Okay. Now, another thing that's important is I keep always saying high amplitude, low frequency waves. Yeah, so what? They're interesting. They're easy to record. They're easy to see. Any of you ever take a course in psychology? In your psych course, did they ever mention something called long-term potentiation? Well, guess what? Learning to memory is nothing but long-term potentiation. You select certain circuits and reinforce them. You even drive those circuits to develop new and more prominent synapses. So synaptogenesis occurs. Look at that. I can touch my nose without thinking about it. That is a series of circuits that already exist in the brain. What's your name?
Sheree.
Okay, good. Shit, work. Did you really think about it? I hope not. A lot of things are coded in our brain by the synapses, the circuits that exist. Learning and memory. Well, guess what? The brain rewires itself to be epileptic. And so epilepsy is actually, if you will, a form of learning and memory. You will potentiate and you will create and potentiate certain circuits that are epileptic. And so, yeah, you would like to prevent recurrent seizures, you'd like to limit seizures because you can and do rewire the brain to be epileptic. One of the many things I do in my lab, one thing we do is we kindle seizures in a rat. We put an electrode into its amygdala, and we give it 5 or 6 shocks. Now, they're not shocks like you think. You touch it, it's like 30 microamperes. And by usually the 6th or 7th shock, they begin to show seizure signs. And after about the 12th to 15th shock, they have a full-blown seizure. We'll do things like we'll look at how you can affect the development of seizures, etc. An important thing is we have created the circuits in that animal so that it has epileptic circuits in its brain. And one of the things we've actually done is that I usually actually work with 16-day-old rat pups, sometimes adults. Well, what we've done many times, just to prove it to my grad students, is we'll take a 16-day-old rat pup, take a bunch of them, and we let them grow up. We let them live there for 2 years. The Animal Institute hates it because we pay $0.25 a day to house a rat. But lo and behold, 2 years later, I'll take the rat, put an electrode back in, we'll give it 1, at most 2 shocks, and guess what? It has seizures. So the importance is the permanence of these circuits. You know we have permanent memory. Well, not during the midterm. We have permanent seizure circuits. And so that's why it's so important to try to prevent this. So seizures do consist of initiation. That's the focal activity, the pacemaker for epilepsy. And then you have spread or generalization. And really, many of the drugs work to prevent spread, and that's good enough, okay? That's supposed to be a Y. Now, you can put an electrode anywhere in a rat's brain. I wish they'd let me use students, it'd be more fun. I can put an electrode anywhere in a rat's brain and eventually make it have seizures. So I didn't say the only 3 brain areas that are the most epileptogenic, but what are the main brain areas that are involved in epileptogenicity? Well, the amygdala, hippocampus, and the prefrontal cortex, okay? In fact, this prefrontal cortex has a lot to do with psychology, motivation, thought, something else that's more psychological. And then epilepsy. In fact, another name for it is the area tempestus, okay? So we do have epileptogenic areas of the brain. And it's kind of interesting that the limbic system is involved there. What else does the limbic system do besides control emotions, autonomics? Emotion, okay? So certainly the limbic system is important. Did you ever hear of temporal lobe epilepsy? That's where some people just might cry, might laugh, or you're close enough. I might have a temporal lobe seizure and grab an axe and cut your head off. So there are some weird seizures. Some people do weird stuff while they seize. Now, so you can trigger seizures. Oh, that didn't feel good. Got my cheeks roll for the day. All right. So the trigger areas are the locus or foci. I'm not going to bother right now. It's too lazy. And and one thing, by the way, if you're working in neurology, for example, my niece's friend's mother, she had epilepsy. They found her focus. Importantly, it wasn't important and it was easily accessible. So they cut it out. She's been seizure-free ever since. Do you think maybe if your focus is like right here, you want the neurosurgeon digging all the way through your brain to cut something out? No. So the most important thing is, one, you have to identify it. Two, it has to be relatively unimportant. And then three, it has to be accessible. Otherwise, all you do is localize everybody's focus, cut it out, and they wouldn't have seizures. So you can't always remove the foci. But if you could, that's great. That always works. When it comes to spread, propagation, or generalization, is there a brain structure? A brain, never mind. That was the A&P class, crap. Is there a brain area you might have learned about that sends like a 3 per second wave through the entire brain, kind of scanning the brain to see what's going on? Well, you're checking to see if I know. The thalamus? Well, what's important with the thalamus is it gets all kinds of ascending information, and it's like a telephone switchboard as well. It sends information to the right spot. So what is a critical area for seizure spread? The thalamus. When seizure activity, you have a locus, a foci, and that sort of spreads through the brain. But there are certain areas of the brain where this epileptic activity hits that really broadcasts it to the rest of the brain. That is the thalamus. Crap, did we cover Parkinson's yet? No, okay, we did that in drugs and disease. Well, another important area for generalization interestingly enough, is the substantia nigra. You guys will correctly usually associate that with Parkinson's disease. But certainly when it comes to focal activity, then being broadcast to the entire brain, it's really the thalamus and or the substantia nigra that are important for propagating seizure to the brain, to the rest of the brain. All right, so let's see. So focus, loci, generalization. You may have focal seizures. You will learn them in your clinical medicine course probably more as partial seizure or partial epilepsies. Neurologists will often call them focal seizures. But quite often you'll see partial seizure. Why? Because they partially invade the brain. They don't really leave the focus very far. So you can have focal seizures. But then when you see people convulsing and all that other stuff, that is the generalized or major motor seizure. All right. Oops, went the wrong way. Okay. This is a new slide. Can you think of another neurotransmitter that begins with a G that would be important in seizures? GABA could be low, you'd have seizures. Glutamate could be high. Okay? So one thing you'll see is many models try to look at counteracting glutamate's effects or enhancing GABA's effect. But I only have GABA here for some reason. I don't know why. Now, I've already given away the fact that eventually the action potentials actually, you're not recording action potentials in an electroencephalogram, you're recording field potentials, mass action potentials. And so what you see is these bounce around in there, and eventually they cause release of neurotransmitters. And eventually you release enough GABA that the seizure stops. What would be helpful on the midterm, is there a drug that can cause seizures that don't respond to other anti-epileptics? Because it's on the midterm. Isoniazid. Isoniazid depletes pyridoxal, that depletes GABA. And so you will be working your first day in an emergency room, they'll bring somebody in having a seizure, you give them lorazepam and nothing happens. Well, see, I would have it easy. I would just say, okay, I'm gonna finish my coffee, too bad, die. Isoniazid seizures are not self-limiting. And there is something called status epilepticus. That's another one. I just finished off my coffee because that status epilepticus always stops because they die and the seizure stops. So I didn't say all seizures don't stop. Most seizures do. Isoniazid seizures will not really respond to anti-epileptics, and there is a form of epilepsy called status epilepticus, where the seizure is not self-limiting. But almost always seizures are self-limiting. All right, now, of all the gajillion different types of seizures, and I'm not going to talk about many of the different seizure types, in neonates, there is cognitive impairment, not retardation. There is cognitive impairment. In fact, they have a really unique electroencephalogram. It has a spike and a dome. Now, have you guys ever seen an electroencephalogram? Well, it just looks like random squiggles. It makes absolutely no sense. There's absolutely nothing to it unless you're trained. You would all notice a spike and a dome, a spike and a dome. Well, that ain't normal. Hypsarthic seizures in neonates. It is actually due to an inflammatory situation, and so you give steroids to limit the seizures. And to some degree, they limit the cognitive impairment. So I didn't say any seizures are treated with steroids except for hypsarthic type. Now on the final one, you're going to have 30 questions, so neither one of those are going to appear in the final. But certainly there will be some unique seizures that you treat differently. I've already said there are partial seizures, partial epilepsies, focal epilepsies, and they may just jitter. An important thing is if your patient has a seizure and they can say, I remember you came over and stepped on my foot, that is a partial seizure. Major motor seizures, there is amnesia of the event, okay? So if somebody is doing something and can recount what happened, right there you know it's not a generalized seizure. Myoclonus is considered a partial seizure. Jacksonian epilepsy is a partial seizure. There's all kinds of epilepsies. Like I said, you may just have twitching of the head. You may have grimacing of the face, something like that. You still probably will treat, there's some cases about that. Generally, you will treat partial seizures because they already have a pacemaker. And so what you want to prevent is the recruitment of the brain to be epileptic. You want to prevent generalization. Then you got grand mal and petit mal seizures, okay? Little disease and big disease. Oh, those funny French, they characterize seizure. What's the seizure? Everybody gets it, but usually kids, where? Wake up, Johnny. Wake up, Johnny. And they're fine. They're back. What kind of seizure is that called? Well, that's a petit mal seizure, or absence. Remember, the French characterized it, so not absence, even though we're in Metro New York, it's absence. Practice absence. Most people won't notice. Snot-nosed neurologists will make fun of you if you say, oh, they got an absence seizure. Well, obviously, you were trained very well when you were trained. They're absence seizures. Oh, so I'm an idiot. I put petit mal second. Petit mal seizures are the absence seizure. You kind of quit moving, you stare off into space, and you're not responsive. So like, by the end of class, most of you guys look like you're having an absence seizure, but I'll say, hey, and you'll all wake up. So that's not absence. Absence seizure, they wake up when the seizure ends. So it sounds kind of funny. You have an absence seizure. You finally lose muscle tone, you fall out of your chair. Well, we laugh at you. You can lose muscle tone. What if he's walking down the stairs up? Or what if he's driving? So absence seizures seem cute. They're generally harmless. Like I said, you fall out of your chair, you fall down the stairs, you drive your car into a telephone pole. That always is a problem. So the absence seizure, the petit-mal seizure, is certainly, I'll agree, less intense than the the clonic and tonic seizures. But they can always convert to a clonic or tonic seizure, or both, okay? And then you have the major seizures, grand mal. And they are clonic. And that's where you have alternating contraction, relaxation of antagonistic muscle groups. So people, if you've ever seen a clonic seizure, they're like flailing all over the place, sometimes foaming at the mouth, chomping and all that other stuff. One thing you guys can do in the emergency room when you get somebody having a seizure, especially if it's like the way most things work, they have it out in the hall, is like somebody should take care of the medical needs, and you should like stick your foot under their head. Why? So yeah, they quit bashing their head on the floor. Epileptics cannot swallow their tongue. You guys want to get an A in the course? Swallow your tongues right now. We have Dodger, our dog. I can grab Dodger, I can pull his tongue out about this far. Dogs cannot swallow their tongues. What do epileptics do when they convulse? They bite their tongue off. They choke on tongue parts, teeth parts, and blood. So don't stick your fingers in their mouth. If you're in an emergency, you got a bite stick. If you don't, stick your wallet in their mouth. Stick your sneaker in their mouth, it's not too far. They can bite off their tongue, they can break off their teeth, they choke on the blood, the tongue, the teeth. Thank God I work with rats. Yeah, rats can't even swallow their tongue. So epileptics do not swallow their tongue, they choke on tongue parts. Epileptics are not intellectually impaired either. They're not retarded. I can't say retarded anymore. Well, that's the old saw. Epileptics are retarded. You have enough seizures, yeah, you could suffer from brain damage. But basically, there's no link between epilepsy and cognitive impairment. Okay? Oh yeah, so the clonic seizure alternating contraction relaxation of antagonistic muscle groups. And then they may have a tonic convulsion, rigid extension, contraction of antagonistic muscle groups. So that's a little more intense. Now, contract your chest muscles for 5 minutes. Start now. What happens when you don't breathe? Nothing good. Do people die during epileptic seizures? What do you think? Yes or no? Or can, let's say, people die? Yes. Usually it is people in tonic convulsions, because in clonic convulsions, the waveforms, the field potentials invade the whole brain, we say, even the cerebellum. Don't really hit the brainstem. Tonic convulsions also invade the brain stem. And so here, these people may die of either pulmonary edema or an arrhythmia. So tonic convulsions are worse. There's a greater risk of death with the tonic convulsion than the clonic, because they do invade the brain stem. And then you have alternating clonic-tonic. You want it to be PAs, so you're going to deal with all this stuff. All right, so you don't need to know this. You need to know this. And this is only for your information. You know, you can look at this. This is not my job to cover this. This is what your clinical medicine will cover. You see there are different kinds of seizures. For example, nothing really here I want, in fact, come to think of it. All right. So yeah, you have all kinds of different seizures. Okay, let's see. You can look at this. This is, here we go. Slide 12. Use slide 12 for the answers for the final. Okay? Now, you will see that glutamate is an important mediator of seizures. And somewhere, where's the AMPA receptor? Right there. Glutamate will activate NMDA receptors, kainate receptors, quisqualate, and even AMPA receptors. Well, what ion channel is the glutamate receptor linked to?
Sodium?
Almost. It's in between B and D. Calcium. You're checking to see if I knew. But the AMPA receptor, that drives synaptic plasticity. So you have voltage-gated sodium and calcium channels rewiring the brain to have epileptic circuits. And you have glutamate activating the AMPA receptors for synaptogenesis. Once again, further strengthening those epileptic pathways. So somewhere here we'll talk about ficoma. But let's see. Many of the anti-epileptics have multiple mechanisms, okay? You'll see here that many of the anti-epileptics that can block sodium or calcium channels influence glutamate release, okay? Levetiracetam, by the way, levetiracetam, Keppra. I'll talk about that. I'll see what they say on 10. Keppra prevents long-term potentiation. So you will see that glutamate is important, all right? Lamotrigine, felmate, these are two drugs that really work more at the AMPA and NMDA receptor. And luckily, for the AMPA receptor, the drug that blocks it, the drug that is an antagonist there, is not here. Well, that's interesting, 2019. I'll have it at the end. It is periampinal ficoma. P-E-R-I, I think. A-M-P, A-N-E-L. Right in the middle of the name of the drug, A-M-P. Think of the AMPA receptor. So, what you'll see, wherever the hell it is, there it is. The AMPA receptor can be an ion channel, but the AMPA receptor is important for synaptic plasticity, learning and memory. And here, I noticed they're also showing GABA for some reason as well. And GABA is important. I think the next slide will be on GABA. All right. This slide ain't too bad, but it's too confusing over here. But I'll stay with the mechanisms on slide 12 for your exam to keep life easy for you. Most anti-epileptics, we now know, have multiple mechanisms too. You know, back when I first started research, we would have to pull, like, say, the amygdala of, say, two animals to be able to analyze. We didn't have the fine level of detection that exists nowadays. So we could only identify drugs that had a powerful action, and we didn't have the finesse to discover all the minor secondary actions. So that's why for years we thought phenytoin only blocked voltage-gated sodium channels. Well, now we know it does many things as well. For you guys, though, for the exam, phenytoin hit voltage-gated sodium channels. Oh, and here's the GABAergic synapse. About the only time I'll mention, I don't even need this. When I talk about some of the GABAergic drugs, that's where I'll talk about glial uptake of GABA and glial release of GABA. Most GABA is not actually stored in the neuron, and most GABA is actually not taken back up into the neuron, but rather glial cells. So here we go. Oh yeah, this is much better. So just memorize this, okay? Retigabine got pulled from the market, so I'm not going to ask you that one. Ethosuximide, yes, calcium channels. tigamine inhibits GABA uptake. Now here's where life is a pain in the neck for you guys. Neurontin and Lyrica. I'll have it in the slides, but it's right here. Neurontin, gabapentin. Gee, what neurotransmitter do you think it works on? GABA. Oh, guess what? It blocks calcium channels. Pregabalin was designed to be a precursor for GABA and release GABA. Does it work that way? No. But it blocks voltage-gated calcium channels. And don't worry, in the exam, I won't put in alpha 1, delta 2, alpha 2, delta. If you see calcium channel, just go ahead and make it. All right? But it is a certain subtype of calcium channels. I'll stay with the fact that these guys block the voltage-gated sodium channel. Oh, here's periamphenol, phycoma. See, peri-AMPA, periamphenol, blocks the AMPA receptor. These I will have slides on. They affect GABA. So pyramate, felbamate have multiple actions, even valproic acid. Depakine, Depakote, have you guys heard of that one? What do you probably see more commonly valproic acid used for, if you've seen it? Yes, sir.
Migraines?
Well, yeah. Oh, very good. Oh, yeah, you said Dr. Resnick, didn't you? All right. She'll be so happy. Well, actually, no, you're entirely correct, and I probably would have eventually remembered that one. Pain management, mood stabilizer, and dementias. Okay? It is an anti-epileptic as well, and as thank God you reminded me, because I probably would have forgot that one. It is used for whatever you just said. Migraine, yeah, thank you. Okay then, you're on a roll with, what did Dr. Resnick tell you about a weird side effect of valproic acid? Hardly ever occurred, but you ought to look out for it. Well, you're checking to see if I know. Elevated ammonia levels. Okay, I'll have it on the slide again. Oh, valproic acid. We develop drugs, medicinal chemists, pharmacologists. Valproic acid was not developed as a drug. It was discovered serendipitously. They were testing anti-epileptic drugs, and they noticed that the control group that was vehicle only had really good anti-epileptic properties. They were using valproic acid, which is a liquid, as a vehicle. So valproic acid wasn't designed as an anti-epileptic. It was actually a vehicle used to dissolve drugs in. So a lot of times drugs are discovered by rational drug design. Sometimes serendipity is important. All right. If you know anybody taking phenobarb, Tegretol, Dilantin, can you see side effects in them? Most likely. At the very least, sleepy, dopey, and goofy. So they're always trying to develop newer anti-epileptics to try to minimize the side effect profile, but also aim at more specific areas of epileptogenesis. Okay? So you see they're still developing new anti-epileptic drugs as well. All right? The bromides have been abandoned. Back in the 1800s, I mean, they only had 4 drugs. So when you had seizures, they would give you a bromide. And sometimes stop seizures. It also destroyed your kidney. So that's not good. Phenobarb, you can see, was discovered early on, phenytoin in 37, and after that, things grew more and more. All right. Oh, by the way, I forgot to tell the pharmacy students, but it's unimportant. Diamox, acetazolamide. I do not have it listed here anywhere. But like whenever you, what's the medicine textbook you guys use? You probably don't know yet. But I can't think. There's a couple standards. Well, you'll probably see acetazolamide, Diamox listed if they give you a table of anti-epileptic drugs. Well, it's not really uncommon to have an epileptic on a couple different drugs. When you finally get to the point where you're considering prayer, you might want to try Diamox. Prayer is more effective. I mean, no disrespect against prayer, but prayer is a better anti-epileptic than Diamox is. Now, don't share that with your patient. We're going to pray too. But Diamox just sucks. As a drug, it sucks. S-U-C-K-S. Pharmacological term for a really poor drug. As an anti-epileptic, if you're using it, don't promise anything, all right? Because it ain't gonna work. Oh, you know something that's pretty good? And I gotta remember to add it in. Cannabidiol, CBD. All right, let's see. I'm not gonna ask you levels. If you work with epileptics, or especially if you work in neurology, you will periodically send them or draw a sample for TDM, therapeutic drug monitoring. And nowadays, you don't have to know nothing because the lab will come back and it will interpret for you what it means and everything. Okay? What you want to be aware of with phenytoin is that look at the effective level of phenytoin and look at where toxicity starts. Okay? For example. So sometimes some of these anti-epileptics, it's not that far to go. Beginning of the year, did I tell you a story about a misadventure with phenytoin in a long-term care center? No, probably not. I sometimes do. Well, in Queens, well, they call them long-term care centers now. Can't really call them nursing homes or something. They had this guy who was an epileptic, and he was on phenytoin. 300 milligrams, 100 milligrams 3 times a day. That's the maintenance dose. Everything's fine and copacetic. For some reason, they enter into the medical record. Phenytoin equals 300 milligrams. Why you would want to like 100 plus 100, 100 equals 300. So then, of course, what happened? Well, then they started giving 300 milligrams 3 times a day. This guy began to show sedation, confusion. He got like tremor, and he was seen by the ophthalmologist. Yeah, that's the doctor of eyeballs, right? Yep. The ophthalmologist in his consult writes horizontal gaze nystagmus. They keep giving the guy phenytoin. He finally develops real severe tremor. The medical director, now remember, yeah, I'll say that. If he was a good doctor, he wouldn't be in a nursing home. The medical director decides, oh, he's having a seizure, and gives him IV phenytoin. Yeah. He didn't die, that's why I laughed. They finally realized this guy was all screwed up, so they sent him to the hospital. His phenytoin level was 57. This wasn't a case I got any money out of. I was just called in like, is that a good level? The hospital quickly detoxed him. They actually did dialysis, yada, yada, yada. They sent him back to the long-term care center. The long-term care center informed the family that he was back and he was well. Did they leave anything out? Like, we caused this? But be aware. They didn't get caught, luckily, but when the state comes in and survey these things, they might have turned that one up. When you make a mistake in this. But this guy had everything but a sign flashing on his forehead saying phenytoin toxicity. And they just ignored everything. So, like, look at your patients. When they start doing something new, it's probably drug abuse, see what they are over. That was the best one. And like, why did no one question, how come we're giving Mr. Jones 100 milligrams of phenytoin 3 times a day, now we're giving him 300 milligrams 3 times a day, when he wasn't having seizures? So, like, you know, the one thing that I'm so glad I work with rats is I listen to my wife, who's a clinical pharmacist, arguing with the new admits where they say, well, the hospital didn't have this on the discharge summary. Or they, well, yeah, you people screw up all the time. So once again, you know, just don't assume anything. I can assume everything, doesn't matter. If I teach you wrong, you can't sue me. All right? So certainly if something seems odd, look into it. I know you're all tired, you wanna go home. Life sucks. Become a professor. Life's a lot easier. All right, this is just for your information. Finally, a drug. Phenytoin, diphenyl, Dilan. I gotta talk to our medicinal chemist. Up until about almost 2000, it was diphenylhydantoin. Now all of a sudden they changed it to phenytoin. Why? So I still say diphenylhydantoin is like a knee-jerk response. For the exam, it blocks voltage-gated sodium channels. Yeah. Well, you know I meant voltage-gated sodium channels. Phenytoin will also prevent Phenytoin inhibits spread more so than initiation. It prevents the recruitment of epileptic circuits in the brain. Once again, I started out by saying when you have repetitive firing of a neuronal net, you strengthen it, you recruit it, you make it permanent, if you will. Well, if you can prevent long-term potentiation, you can prevent seizures. But phenytoin is predominantly a propagation inhibitor because, once again, the seizure has to spread to involve most of the brain to be a major motor seizure. So phenytoin is usually called a generalization inhibitor, inhibits spread, whatever. It does block sodium channels. It blocks the sodium channel activity is what's needed to recruit these circuits, okay, these epileptic circuits, for long-term potentiation. So I'm not gonna ask you that. All you need to select is blocks sodium channels. So you don't rewire the brain to be epileptic, you attenuate or slow down the repetitive signals that are trying to be epileptic in the brain. So it is a spread or generalization inhibitor. It can be used for all seizure types. Now, if you have partial epilepsies, phenytoin work. But do you want to, like in the case of their partial seizure, you maybe want to give them phenytoin when you might have a less toxic or drug with fewer side effects? So you don't start off with phenytoin. On the other hand, with major motor seizures, we use phenytoin. Now, absence seizures, what sometimes happens, not always, you convert them to clonic seizures. So that's why they say you don't use phenytoin in absence seizures. Phenytoin would actually stop your absence seizures, but like I said, you kind of zone out. You want to use a drug like phenytoin to stop people from zoning out. Now, phenytoin will always cause sleepy, dopey, and goofy. More so than the other sodium channel blockers, phenytoin has been shown to impair learning and memory. Oh yeah, no crap, Dr. Wurpul. You just said epilepsy is a form of learning and memory. Well, also, especially like you guys, but especially kids, what are you trying to do now? Trying to learn and remember. What are children trying to do? Learn and remember. So by blocking learning and memory, yeah, you're preventing the brain from learning to be epileptic. You're also making it really hard to learn and remember stuff. So you might do better with kids to try to give them Tegretol, okay, carbamazepine. All right, let's see. This is not a mistake. Nausea, vomiting, constipation is a more common side effect. I better have nystagmus in here somewhere. Oh, crap. Ah, damn. Okay, right in nystagmus. All right. I see, where hell did I see? Slurred speech, ataxia, and vertigo. Phenytoin is a cerebellar toxin. So, oh yeah, last Friday night was the last weekend of your break. So maybe some of you went out and had one Long Island iced tea too many. You know, that has cerebellar toxin. You may have vertigo, ataxia, staggering. And so when the friendly policeman pulled you over, what did the friendly policeman do? Probably told you to follow his pen without moving your hand. And what will you do to your patients? You'll have them follow your pen without moving their head. And nystagmus, horizontal gaze, you'll see it flicks to the right or left, it returns to center. That's what shows up first in cerebellar toxicity. Me, I just wait till then you know they got it, you don't have to wonder. So that's where you would do a benefit. Look at their eyes, see if you see nystagmus first. The only reason I say horizontal gaze, there's also a vertical nystagmus, which is due to the other causes. So, phenytoin. How do I forget the name of the drug while I'm talking about it? Phenytoin, if you remember, cerebellar toxin, nausea, vomiting, vertigo, ataxia, and the first thing you see is nystagmus. One of the problems, notice I keep saying cerebellar neurotoxin. Do neurons replicate? No. So when you have phenytoin overdoses, you need to worry because you may have permanent neurotoxicity. Okay, you can get rashes, you can get cerebellar toxicity. Megaloblastic anemia is associated with phenytoin. Oh yeah, pregnancy. When you're pregnant, your seizure threshold goes down. Eclampsia, preeclampsia, eclampsia, you're more likely to seize. The hormonal changes in pregnancy, you're more prone to seize. If you're an epileptic and pregnant, you're more prone to seize. Anti-epileptic drugs are all fetotoxic. Seizures are not good for the fetus. So you guys, if you have a pregnant epileptic, will certainly have to work through what's the best drug to use, okay? But all anti-epileptics have some kind of teratogenicity or fetotoxicity. But I point out the fact that seizures aren't good for the fetus either. So that's why I like working with rats. I make a mistake and I say, sorry, Squeak. I should have put that in there. Certainly phenytoin used to be in the, well, still in the top 4 of drugs that cause Stevens-Johnson, but it can cause hypersensitivity reactions. To make your presentations look big, put the same thing in twice. Nausea, vomiting, constipation, and then constipation. Sorry. You gotta look at liver function test. Liver function problems more so than nephrotoxicity. Phenytoin can even cause osteoporosis. But since you're aware of that, you should be monitoring them long before that. So hopefully they only get osteomalacia. But in fact, many anti-epileptic drugs can cause osteopenia, osteomalacia. Wait. I forget which one comes first. Or osteoporosis. Oh yeah, you guys are taking patho, right? If you learn about osteo, whichever, write down which one comes first. I think it's osteopenia, then osteomalacia, but I don't remember. If I ever took a course in pathophysiology, I know what the hell I was talking about. All right, encephalopathies, headache, insomnia, slurred speech, confusion. Okay, other blood disorders, but most commonly, not the only, but if you had to pick, I'm not going to ask you this, but what's the most common blood disorder with phenytoin? Megaloblastic anemia. All right. Did they cover blood in AMP yet? Well, the megaloblast is that great big cell that has a whole bunch of eventually little red blood cells in it. All right. Crap. It can cause DISLE, D-I-S-L-E, drug-induced systemic lupus erythematosus. When you learn about that, it's clearly indicated because it will have different autoantibodies than the genetic variant. And very rarely, not as often as I dress nicely, phenytoin is used as an antiarrhythmic drug. If your other antiarrhythmics aren't working, it has to be a 1B antiarrhythmic. All right, when I don't remember when we started this fall term, I sometimes talk about like some prototypic drugs, including phenytoin. I think I skipped it. Phenytoin, does phenytoin have a constant half-life? Yes or no? What we always say drugs have a half-life, like, penicillin's gonna be about an hour for everybody. Phenytoin, no. The half-life varies with the dose, or really the blood concentration. Shows saturation kinetics, which I do have in there. And so what you see with that is when you increase the dose of phenytoin, its elimination rate briefly goes down, and you might overshoot the toxic range. Or if you want to drop phenytoin levels, you reduce the dose, it might go too low and you might have a few seizures. So what you see is that phenytoin elimination responds to plasma concentration in an inverse way. And so unless it's emergency, when you're adjusting phenytoin doses, you do it on a weekly interval. Now, phenytoin is highly protein bound. Do you think now, if you take another drug and it kicks off some phenytoin, that affects its elimination and its levels? Yes. Or you take a drug away and more binds up. So certainly phenytoin, you'll see sometimes, I think it will just change, drive you guys nuts. But you will see that you can have fluctuation in phenytoin's levels and phenytoin's effects. Okay, because of, like I've seen books say phenytoin half-life, they give a number. Of course, usually I see the numbers like 6 to 48 hours. That's not helpful. I put roughly 24. But even there, it's going to vary based on what the present plasma concentration is. Okay? Now, phenytoin has a lot of problems. Phosphenytoin, Cerebrex, more rapid, absorbed more rapidly, more effective, fewer fluctuations, okay? It's a prodrug. That's all I have. Oh, you see, it works within 7 to 15 minutes. It's a prodrug. It's activated by phosphatases in the body. I think it's due to cost, is why you give phenytoin dilant to treat your patients, like outpatients or whatever you call them. But in a seizure emergency, phenytoin. And I get 30 questions, so I wouldn't even ask you if it's a prodrug or anything, but it's phosphatase is activated. So phosphenytoin is actually better. Phosphenytoin also has fewer side effects as well. All right, so let's see. Phenytoin. Blocks sodium channels. If I were to ask you side effects, hopefully the tip-off would be horizontal gaze nystagmus and megaloblastic anemia. I'll have other stuff in there so if you read it, you'll learn something. But, those are, especially the megaloblastic anemia, I guess really, I think that's what you ought to look for the most. But as a warning of cerebellar toxicity, look at their eyeballs. I don't remember, so I'm not going to guess at what I think I remember on how often you do AST and ALT in these folks. But you will have to look at hepatic function as well. And phenytoin does interfere with learning and memory to a significant degree in everybody, especially children. Oops. Okay, I already said phenytoin has saturation kinetics. Oh, this won't be your job, luckily. This will either be the lab, or if you're in like a clinical situation, you get the pharmacist to correct phenytoin levels. Okay? You'll see the phenytoin levels are also influenced by albumin levels. Oh, you know what? There's probably an app on the cell phone to do that now. But like, you don't want to wait for the lab to come back. Yeah, you could like look that up and do it, but that's the job of the clinical pharmacist, okay? Many neurologists can do this in their head, so like that's another good thing. And you don't need any of this. I just put in some of the side effects correlated to plasma levels and all that stuff. All right. Okay, Tegretol, carbamazepine. For the exam, pick blocks voltage-gated sodium channels. That's all. But by blocking voltage-gated sodium channels, it blocks spread through the brain. Can be used in all seizure types except absence. And it was with Tegretol, another old drug, where we began to see the importance of blocking other ion channels. To make your life simple, I will not have calcium along the answers when I ask you, if I ask you about Tegretol. So it blocks voltage-gated sodium channels. Another way of saying what it does to the brain
is it reduces the rewiring of those circuits, production of polysynaptic responses, blocking long-term potentiation. Another term for it is post-tetanic. When you are recruiting circuits in the brain, you're preferentially firing these circuits, you're strengthening those circuits, but you're also creating synapses. The sodium channel side is the strengthening of the wires. The connections will be the AMPA receptors, okay? The new synapses. But for you guys, carbamazepine blocks sodium channels. All right, let's see. Pretty much the same side effects. Where is it? A unique side effect associated with carbamazepine. Phenytoin has been reported to cause hyponatremia, very rarely. Carbamazepine, in some cases up to almost 30% will have hyponatremia. Now me, I'd wait until they went into shock. They got below 118. And, oh wow, shit, oh man, they're hyponatremia. And now it takes 3 or so days to fix it. What are the first signs of mild hyponatremia? Sleepy, dopey, and goofy. And I didn't say this, but like in mild hyponatremia, they only say down around, say, 127. You give a score to 3% saline, correct everything, and that's it. When you learn about electrolyte disorders in your clinical medicine course, you usually correct them over 3 or 4 days. Mild hyponatremia, give a score of saline, you fix everything. Like I said, if they're in shock, well, that's too low. So mild hyponatremia, and you kind of want to look at that. Let's see. You see nystagmus, vertigo, tremor, double vision, yada, yada, Stevens-Johnson. Basically, I should have just cut and paste all the same side effects, okay? There is anemia, megaloblastic, all that other stuff. Okay. I'm not going to ask you, like, half-life. There is a constant half-life of carbamazepine. All right. Relatively highly protein-bound. Trileptal is a active metabolite and is marketed as oxcarbazepine. It has more constant kinetics. So whatever your medicine faculty tell you, whatever your doctor tells you, I agree with. But if I had to pick, I would pick the trileptal. That's more constant kinetics, okay? And I see liacarbazine, which, what luck. Liacarbazine is the newest introduction. It's a carbamazepine derivative, and it blocks voltage-gated sodium channels. It is a prodrug, activated to oxcarbazepine. All right. Notice S, liacarbazepine. Fewer side effects than carbamazepine. Fewer side effects and less intense. And so I don't know what it costs, but if it's not super expensive, that might even be the way to go. Nice kinetics, good prodrug, lacks much of the side effect spectrum or less intense in the side effect spectrum than carbamazepine, okay? So you got trileptal, which is kind of like a prodrug or active metabolite, and now you have the newest one, Aption, S-carbamazepine. It's a prodrug. It is S-licarbazepine, gives you S-carbamazepine. Basically, like I said, side effect profile is less intense. I might have mentioned this to you guys at one point. Why is it some drugs, they actually go to the bother to take out one racemate, take out, say, the S form, which is usually biologically active? Because the D form is usually not pharmacologically active, but can give you side effects. That's why they often take out and make a single racemate drug. All right. Oh, the other nice thing, better kinetics, but also look at the protein body, much lower. Oh, and one thing, most recently I saw a couple publications, very few interactions with the cytochrome P450 isoform. All right, so Copri, cenobamate. All right, geez. You can see this is a newer slide, so I'm using newer acronyms, but blocks the voltage-gated sodium channel. And when you took anatomy and physiology, especially cardiac, they might have talked about the upper activation gate and the lower inactivation gate. Well, in fact, the voltage channel blockers, the voltage gated sodium channel blockers, all work at the inactivated state, okay? And it's only the sodium channel that has an upper activation gate and lower inactivation gate. If you close the gate, you don't get it. Okay? Let's see. At your house, you have a pit bull that kills people. So you probably have a fence with two gates. As long as one of them's closed, nothing gets out, right? So it happens to be the lower inactivation gate that binds there. All right. Once again, we're seeing that the newer anti-epileptics with our better analytical capabilities, there is an increase in GABA transmission, and it's inhibiting reuptake. So there's an increase or pre-synaptic release of GABA. But for the exam, VOCNA. Is that on slide 12? Oh, you're out of luck. So write cenobamate in that upper right box. I'll just accept block voltage gated sodium channel. All right. Reasonable half-life. Protein binding, nothing to worry about. And is biotransformed by 3A4, 2D6, 1C9, and even glucuronidase. So in English, few drug-drug interaction because it has so many elimination routes. Not highly protein bound, so that's good. That's supposed to be somnolence. I guess I got lazy or something. So, somnolence, I'm very sorry. Nausea, vomiting, diarrhea, somnolence, fatigue, dizziness, lightheadedness upon changing posture, and drug reaction with eosinophilic syndrome, DRESS, the DRESS reaction. You may have rashes, you may have a mild asthma-like response. Okay? So DRESS. That's not what I wear when I go home. Drug reaction, eosinophilic syndrome. Okay. Oh, good. Zongran, I see it right there. Blocks the voltage-gated sodium channel. Mostly appears to inhibit initiation, so I'm not going to ask you if it blocks initiation or spread, because it does block the T-type calcium channel. And so it blocks initiation, certainly blocks spread. If it's on 12 especially, I'm going to take blocks voltage-gated sodium channel. I'm trying to keep it simple to a single answer for the final. 10 years from now, unless I retire, we may know something different. The things I knew about some of the, quote, older anti-epileptics is totally different than years ago. So they're constantly changing. All right, low protein binding, nothing important to say. Take out the question mark. Nausea, vomiting, diarrhea, drowsiness, paraventricular function, and nephrolithiasis are associated with zonisamide. Okay, Lamictal, lamotrigine. You may hear about this in pain management, and if you're desperate and nothing is working in the manic phase of a bipolar disorder, then you might try it. It's not your first or even second line bipolar. It's sometimes used as a mood stabilizer. All right, blocks sodium channels, suppresses release of both glutamate and aspartate. So with this one, oh yeah, that should be so bad. Blocks VOC, I have it in the same line. Blocks VOCNA and reduces, release, suppresses glutamate aspartate release. And in fact, this is probably more important. Okay, it's used for partial seizures, secondarily generalized seizures, all types of seizures. Not many side effects, dizziness, ataxia, somnolence, but there have been skin eruptions. Sometimes significant skin eruptions with this. So with Lamictal, sodium and glutamate aspartate. Blocks sodium current channels, reduces glutamate aspartate levels. Okay, valproic acid. I think on slide 12 it pointed out GABA transaminase. I'll look at slide 12 to make sure I don't stick it to it, but I'm pretty sure it said GABA transaminase. So that's the party line, and I'm sticking with it. Back when it was first released, that's what it looked like it did. Here's how pharmacology works. When we look at something and we don't know how it works, we say, the mechanism is poorly understood. That way you think, we kind of understand it, but you're not smart enough to understand what we try to explain. When in fact, we have no idea how it works. Then if you discover anything, that's the mechanism. And so what did they discover with valproic acid? It appeared that they had data that indicated GABA levels went up. And so they said, oh, it inhibits GABA transaminase. One of the problems is, years later, when any of us try to give valproic acid with the GABA levels, they don't go up. That's science. Does block GABA transaminase weakly. Importantly here, what you see is they thought, well, has some effect on sodium channels. Oh, maybe it's important because the valproic acid gets to synaptosomes. You have any synaptosomes in your brain? No. That's when you grind your brain up, spin it down, and all the synapses come together. So that's worthless. What do we now know about valproic acid? Well, histone deacetylase is very important for gene expression. Oh, golly, Merle, ion channel. Holy crap. And guess what? Sodium and CA, calcium ion channels are blocked. Inositol and the mitogen activated protein kinases, inositol synthesis and MAP are critical for synaptogenesis. This is neuroinflammation. That's never good. GSK3 inhibition. Did we cover bipolar disorder yet, you guys? First semester, I think we did. I don't know what the hell we did. I don't know what we did in bipolar. Well, in bipolar disorder, lithium affects glycogen synthase kinase 3 beta. So mostly think of that for bipolar disease. But in fact, by suppressing GSK3 levels, guess what happens to the brain? Glutamate goes down, GABA goes up. So once again, this whole thing that many anti-epileptics have a whole bunch of little mechanisms that back even 10 years ago were hard to pick out, hard to discover. And so you found anything, you reported it. What we now know is many of these drugs work by a bunch of little mechanisms that all come together, and the sum is greater than the whole is greater than the sum. So for the exam, pick GABA transaminase. But then when you get on your clinical sites, you're talking to physicians, say, well, certainly they used to think it blocked GABA transaminase, but newer evidence points to many downstream mechanisms. Then hope they don't ask you a lot, they probably don't know either. All right. Now, I hate me. I hate me too. Ammonia! Right, ammonia! Hyperammonemia with valproic acid. I'm sure it'll be in the slide. Do me a favor, somebody send me an email about adding it. I'll just, I won't put it in this presentation, but I'll put it in the one I'm keeping for next year. A weird, rare side effect of valproic acid is elevated ammonia levels. And you'll see changes in mental status. The patient will have a fruity breath, decrease in sensorium, and if you wait long enough, you'll cook their liver. It's a rare side effect, and if it was like a rare side effect that was unimportant, I wouldn't say it. But hyperammonemia really can have a negative output for rarely felt. So ammonia levels. And I don't say you should ask for a lab test for ammonia in every patient, because everybody, including me, would think you're nuts. But if your patient's been on this for a while and you're seeing a change in their sensorium, maybe you consider asking for ammonia levels. Or you just walk up and smell their breath. Yeah. Another reason I'm glad I work with rats. I'm not smelling their breath. I'm not letting a rat anywhere near my nose. Oh man, I am a wonderful person. I didn't laugh at people today. They've asked us to go into the pharmacology labs the faculty, senior faculty, because there's been some problems with the students not listening to grad students. Well, I was dying. I didn't laugh, I didn't even smile. This was the first time these students ever had to handle animals. I was dying. Now, I can vaguely remember the first time I had to pick up vermin. Yeah, it's not natural. But it was just like, see, that really sounds like a dying puppy. You just pick the damn thing up. And that was a guy. I'll tell you the truth, the women were better picking up these things than the men. So yes, I'm going tomorrow to get my laughs. I'm so proud, I didn't mean to smirk. But I'm like, Jesus Christ, why that bad fruit I picked up something? Did you guys ever have to handle animals as undergrads? Yeah, man, what the hell? They bite up like back. Oh, ammonia. You see all these side effects. Unfortunately, I left out ammonia. It is rare. So don't look for it in everybody, but also it's an unusual side effect that can have an important consequence. I like this. Disturbances in thinking. The marketing departments are so imaginative in how they describe side effects in drugs. Okay? Impaired cognition, confusion, sedation, impaired learning, etc. And certainly fetal malformations. No, don't worry about that. That's for the pharmacy students. All right, the gabatrin inhibits GABA transaminase, which would elevate GABA. What's the starting material for GABA synthesis, by the way? Anybody remember when you took anatomy and physiology? Glutamate, yeah. And indirectly, when you break down GABA, you break it down into succinic semialdehyde, and there's a Krebs cycle, it comes back out as glutamate. And most of your GABA cycles through glial cells, in fact. So, the gabatrin, Sabril, inhibits spread. It's used in all seizure types, and it is shown to be effective in those resistant to like phenytoin, tegretol, etc. So that's good that way. Nothing really unique here except notice psychosis, worsening of psychotic symptoms, okay? Either while you're on it or when you withdraw. So with the gabatrin, you don't have as much sleepy, dopey, goofy. You don't really see much in the way of blood disorders. You don't see much in the way of cerebellar toxicity. But you might see mood changes, psychoses, or worsening psychoses with the gabatrin. All right. Tigabean. You don't care where it works. I put in cortex and hippocampus, yeah. Tigabean inhibits the GABA reuptake pump, okay? So it inhibits GABA reuptake, therefore GABA levels remain high. And I'm not going to ask you that, but I've said many times, GABA is taken mostly back up into glial cells. And GABAergic neurons generally get their GABA from glial cells. So it's one little difference in neurotransmitter physiology, I guess. But gabatrin, tigabean, inhibits GABA reuptake. And there are actually different GABA reuptakers. It works throughout the entire brain. But what are two of the most epileptogenic areas in the brain? The cortex and the hippocampus. And what you see is that's where you have these startling increases in GABA levels. Really noteworthy. So it works good. All right. Interestingly, it elevates GABA, but it may cause anxiety, emotional lability, and psychosis. Okay? Yeah, lability, emotional lability. First you're happy, then you're sad, then you're whatever. Okay? Ethosuximide blocks calcium channels. Oh, good, yeah, I got that there. I saw up here. Suppresses paroxysmal 3 cycle per second spike in wave activity. What the hell does that mean? That's the information that goes to the thalamus. Say, hey, Thally, pitch a fit. That's when you now send the seizure activity to the rest of the brain, okay? And what is important there is the transient T-type of calcium channel. For you guys in the exam, pick calcium channel, VOCCA.
So it prevents is the message even going to the thalamus, or it stops
Well,
the thalamus from
it
sending?
reduces it.
Okay.
It's probably blocked completely, or it doesn't really get there much. Okay? Because once again, it is the thalamus and substantia nigra that now take this epileptic signal and blast it through the rest of the brain. You know, years ago, we thought it was just random, that these act potentials just bounced around inside the brain like a demented chipmunk. Well, actually, demented chipmunks have pathways to follow. All right? Nothing really unique. Oh, by the way, systemic lupus, this here, by the way, is now called DRESS, drug-induced eosinophilic syndrome. The old term was drug-induced eosinophilia. The new term is DRESS, drug-induced eosinophilic syndrome. And yes, drug-induced eosinophilic syndrome. I don't know where that second S comes from. Oh, okay. Ah, I believe it, because all right. It's either systemic or systematic. All right, I believe you. Good. Let me see. So that's DRESS. All right. Let me see what's next. Phenobarb. It'd really be nice if you could not use phenobarb, okay? Do me a favor. Just don't use it if you can. Oh, yes, ma'am.
On the last slide, it says seizures, so does it treat and cause seizures?
What was that?
On the last side effect, it says seizures.
Oh, yeah, can cause seizures.
Okay,
Yep.
just making sure.
Oh, yeah, no, that's not a mistake. Yep.
Okay.
Some people get it and they have more seizures. All right. I mean, phenobarbital works, but it is a powerful enzyme inducer. I'm not going to ask you to know which one, but it is a powerful enzyme inducer. It is also the most sedating of the anti-epileptic drugs. And the barbiturates prolong the duration of chloride channel opening. It enhances GABA actions. It inhibits synaptic transmission because it prolongs the duration of chloride channel opening. So you have prolonged hyperpolarization in the brain. I'll wait till we do anti-anxiety drugs. But it's pretty easy to kill yourself with phenobarb. Okay? Later, when I talk about the difference between benzodiazepines and barbiturates, I'll point out although they appear to do the same thing, they work different ways. But this one, you get prolonged hyperpolarization in the brain. Can inhibit seizures, but it can be problematic. Okay? So, I'm not even going to ask you phenobarb. When, way back, when they only had like 5 anti-epileptics, and phenobarb was one of them, it was a good drug. Nowadays, you're not going to be starting them on phenobarb. Same with the benzodiazepines. I'm going to talk about the benzodiazepines under anti-anxiety drugs. If all you have in your pocket is alprazolam right now and somebody starts to seize, will it work? But usually you choose diazepam, lorazepam, or midazolam. On the other hand, if you send them home with a prescription, it is clonazepam, Klonopin. Okay? And I'll talk about the benzodiazepines then, but they enhance GABA binding, so that's correct. LOR is lorazepam, DZP is diazepam, and I gotta add in midazolam, some places use. Seizure protocols usually call for lorazepam, okay? But like I said, whatever you have in your pocket probably works. And you don't need to know half-life, but I have clonazepam in there, because if you prescribe clonazepam, well, that's it. If you send them home with a prescription, you're probably gonna give them clonazepam. I wish I should have went to med school. Then I could abuse people instead of rats. When I talk about depression, they sometimes use clonazepam in agitated depression. So now you have sedated depression. They would not here let me do that to rats. So keep that in mind. Also, what is the most addictive of the benzodiazepines, do you think? So since I was just talking about it. Clonazepam. Clonazepam is the most addictive of the benzodiazepines. So, If you need to use it, that's fine. If you have a person with anxiety or sleep disorders, you're probably better not to use clonazepam. If you have somebody with epilepsy, you're probably better not to use clonazepam. And I don't really know how often agitated depression occurs. That's where they use clonazepam, so now you have sedate depression. Oh crap, what time is it? I didn't set my timer. You guys are as subtle as a nuclear bomb. Oh, sorry. Oh, geez. Hey. Yeah, sorry about that. Yeah. Oh, and then 30th, you have an exam with, never mind. You have an exam with Dr. Shady, right? You're going to get part of the time.
On the 30th.
Yeah, on the 30th.
On the 30th.
Oh, were you here all that time? Why did you tell me to shut up? Or did you just walk in?
I walked in longer than